Skulle jag vilja be Rikard Wedin, har vi det där, komma fram. Du är forskare och läkare vid Karolinska Universitetssjukhuset och har en hel del spännande saker att berätta för oss. Så varsågod.
Hoppas det. When I was in med school, my father was diagnosed with prostate cancer with skeletal metastasis. And that's probably why I chose this field of research. I got to talk a little bit about cancer, clinical decision support, and estimating survival. Because sooner or later, as a doctor, you have cancer patients, you will get this question. And doctors don't really want to answer this question because of the obvious risk of being very, very wrong. There is no objective way of estimating survival, so the patients are often left in uncertainty. My name is Rikard Wedin, I'm at the Karolinska. This is my American colleague and friend, also orthopedic surgeon, who works at the Johns Hopkins, and Walter Reed. He wrote this thesis about how you develop a clinical decision support by using machine learning and patient data. I was his mentor. When cancer spreads or metastasizes to the bone, the patients are incurable. And these tumors, they afflict pain, fractures, paresis when the tumors hit the spinal cord. And this afflicts 75% of all patients with breast cancer, half of the patients with advanced prostate cancer. And these fractures caused by cancer seldom heal. And the bone quality is very bad, so this results in lots of complications and lots of new operations because of failures. And that's a catastrophe if you have a median of 7 months left to live. To reoperate the fractured cancer patients is one of the most expensive standard operations we do at our hospitals, and the costs are increasing. We have more than 10,000 new patients with skeletal metastasis in Sweden every year. 1 out of 10 of these patients will end up on our operating tables. Estimating survival is very important when you decide on the medical and the surgical treatment. If you have a long expected survival, like this one to the right, you need a very durable, complicated construct that demands a long rehabilitation. If you have a shorter survival, like the one in the middle, you don't have time with long rehabilitation, you need other constructs. And finally, here to the left, if you have a very short survival, you don't benefit from surgery at all. And when the surgeon decides upon the treatment, that decision will not only affect the patient, the cost of the implant, but more importantly, about the duration of rehabilitation, and that is often the most costly in this patient's care. If you choose the wrong treatment for the wrong patient, it's harmful and it's costly. Prognosis is good for many other reasons. It can be used as a criteria for hospice care, like in the US. And not only it's useful for surgical decision making, but also medical decision making, like the very difficult question about chemotherapy in the last months of life. Most importantly, it helps set patient expectations, and it helps them to keep quality of life as good as possible in the end stage. We are working on several clinical decision supports, combining machine learning with patient data. Our first one is called PathFX, and it estimates survival in patients with skeletal metastasis. This was one of my patients some years ago. She was previously healthy. All of a sudden, she lost function below the waist. She couldn't walk. And investigation shows this. One of her vertebrae in the spine had collapsed, and later it proved to be metastasis of breast cancer. And it presses back on this gray cord, which is the spinal cord. So that explains the reason why she was parotid. So, what treatment? Surgery or just radiotherapy? It's generally agreed if you have less than 3 months to live, it's only radiotherapy. There's no benefit of surgery because of the complication risk, because of the need for rehabilitation. And then I turn to our decision support. It will ask you 11 questions about what type of cancer it is, the spread of the cancer, some laboratory tests, and then a function score. And it immediately provides you with this, which is the probability of survival. So this patient has around 70% chance to live 3 months, 32% chance to live 12 months. So she was absolutely a candidate for surgery. And I operated her, and this is the X-ray afterwards. And she did regain full function in her legs. So this is an example of individualized patient care, precision medicine. How do we know it works? This is the science behind it. To prove it works, you need to externally validate this decision support. And it's up to now, it's done in 4 regions, and there's more regions on the way. They've all been successful. This is an economical study from Memorial Sloan Kettering in New York. They have calculated the savings they would do if they got the treatment right from the beginning, no mistakes. So they ended up in a median savings of $3,700 per patient. And now the healthcare costs are a lot higher in Manhattan than in Sweden, but we would also here make significant savings. PathFX is freely available on the web right now, if somebody's interested. Doctors around the world can use it. Much better is it if this is integrated in a patient medical record, because the computer will answer half of those 11 questions. No logins, no ads. Most importantly, though, is that if you incorporate this in a patient medical record, you structure the data, you are able to standardize the treatment so they will make the same treatment decisions in small hospitals in the countryside, same treatment decisions as we would do in the Karolinska. And that optimizes the treatment. So how do you make a clinical decision support? We need a constant inflow of patient data to be able to keep it on its toes, to make it better and better, and to train the algorithms. So practically you need a quality registry, then you need some complicated statistical analysis, and then you need to externally validate this to prove it's working. So you could use this in any area of the healthcare. So what is your most expensive problem? As I said, we need to constantly update the algorithm for PathFX. So we have started our own registry together with a regional cancer center here in Stockholm. It's called the International Bone Metastasis Registry. Now, 2 years later, we have all these well-renowned cancer centers that send us patient data. And why do they send us data? Because Sweden has a very good name in quality registries, because it's free. I pay it right now with my research money. It's a large database, excellent opportunities for research. They could use it as a quality control for their own department. That means that the guys in Singapore can compare themselves to Manhattan, to Karolinska, and ask what do we do right, what do we do wrong. What's in it for me? Same, great research, but importantly, PathFX is continuously improved with quality data. And most important, what's in it for the patient? They get less complications and safer care. So, in my opinion, there's 3 winners with the clinical decision support. The patients get better care, the doctors have less complications to worry about, and the healthcare providers, they increase the patient quality of life. and they save money. Small hospitals, few patients in general, they have difficulties in keeping up with treatment of rare diseases. And integrating decision supports in the patient medical record would standardize the treatment and help them make the same decisions as we do in Karolinska. And finally, if we didn't have this continuous data coming in, we would close down path ethics maybe 4 or 5 years, because there's new cancer treatments every day. High quality research for the future needs high quality data. Thank you.
Thank you very much. This is, of course, very important research that you do, and I invite you to ask questions again, and if you don't, I will. I would start off then. I'm thinking, you've seen very good results of what you're doing, and you're doing it on research money, is that correct?
Yeah.
How long will that last?
Until next year.
Until next year. So what would you like to see happening with this project and your knowledge and what you're doing?
I would like the Swedish County Council to grab this project and test it and finance it for a year. It's small money. And we could prove that it actually saves money.
And I was thinking about the data from New York that you were showing, and of course, they have another price tag, but we still have an issue in Sweden that healthcare is a large part of the budget and we want to control it somehow. So I'm sure some of the politicians here might take that to heart, that if this is a way of knowing more in order to save money and treat people in a better way, it should be encouraged, to say the least.
If you saw the price tag of those reoperations we make, it shouldn't be a big thing. They are very expensive.
So we need to maybe translate that equation a bit maybe into politics. Any reactions or questions? Karl-Johan, please.
Just a quick question, Rikard. Because that's your wish, I understand. But could you describe a bit more why there is maybe lack of interest or disinterest or even legal obstacles? So why isn't this picked up by one of the county councils and then just implemented?
I don't know. I think uncertainty. I don't really think everybody understands how it works and what good it is. I think that's the simple answer. I find no other reasons why.
What about the innovation spaces that you find in